So one of the things that we have to do when we transition people into these new plans is we have the non-choosers. So for example, if we picked, say, our first county for September was going to be New Haven County, and notice would go out to all Husky members early in August saying, you have to select from one of these new 3 plan options, and then typically for people who don't select, they get assigned on a default basis, which we rotate just on a default rotating assignment. This time, because we want to be a little bit sensitive to the fact that these folks have been subject to a lot of change lately, we're not going to default anybody until the end of the November enrollment cycle. So for the first 3 months, this will be only positive choosers. The defaults will hold off until the end of the transition period. In addition to what we're doing with Husky and Charter Oak, as though that wasn't enough to keep us busy, we're working on a new delivery system. This is, you may have heard about in your presentations from our friends down in North Carolina, where they have one of the more successful programs. It's called PCCM. It really stands for the Primary Care Case Management. And what this is a managed care option, but it's managed care not through a MCO. It's managed care basically where a physician group or group practice or federally qualified health center agrees to provide certain kinds of medical home coordination. And in exchange for doing that medical home coordination for a patient, they receive a per member month reimbursement. And they would accumulate a panel of clients for whom they would basically become responsible for coordinating care, making appropriate referrals. We're hoping this is the kind of thing that would really be enhanced by an electronic claims record, similar to what Tom's comments were about how you make referrals to specialists. And we have some ventures in the state right now. I think Margaret's venture down in Middletown is a pretty good example of how that works. We're targeting that for October 1. We think that would be a really nice enhancement to the whole transition process in terms of giving Husky clients in at least certain pilot areas. We don't expect to be able to have enough physicians or clinics enrolled to do PCCM on a statewide basis come October. But at least in certain geographic areas, there's a strong component in the Waterbury area. There's a strong component in the New Haven area. I think New Britain looks pretty good. There's certain geographic areas in the state where we think this will be a viable option. And then as it spreads out, and proves successful, we could have additional areas join in as well. A little note on... Yeah.
Just a quick question. I think that's very exciting. I'm looking forward to it beginning to roll out. I saw you said that it's under internal review to get to the committees, but is that the report that was supposed to be turned in the committees?
That is the report.
Okay.
That is the report, and that's been taking a while to get that done. Although during the time that we've taken to sort of complete the report, we've actually gotten a lot more work done on it, in that we've really filled out a lot of the budget detail and some of the additional questions about what we think the PMPM to the doctors are going to be, what we're going to budget for ancillary services. One of the ideas, we've had a pretty good working relationship with an advisory committee that's helped us with this, some of whom are in the room today. I see Ellen Andrews over there. In terms of adding additional supplemental services like a nurse hotline, which MCOs have, but most doctors can't afford on their own. Maybe we'd go for a contract to do that. So all of that's in there.
Do you have a sense when the committees will get their report?
I would think very soon. Very, very soon. Right. Okay, I want to move on and talk a little bit about dental. We've mentioned a little bit here today about the difficulties of Medicaid reimbursement and what that means for our clients being able to receive services, and probably there's nowhere in the world of Medicaid where that issue is quite as profound as it is in the area of dental services. We've had really kind of a dismal record of retaining dentists in the system and seeing our kids get served. One index of that is what we call our EPSDT, Early Periodic Screening, Diagnosis, and Treatment, where we try to measure how many kids are getting all the wellness visits that are mandated by federal and law and the American Academy of Pediatrics. And on the medical part of wellness visits, we've actually shown some improvement. In some age categories, we're actually at the 80% level, which is the prescribed federal level in terms of the percentage of kids that are compliant with the full regimen of wellness visits. But on the dental side, we're probably only at about half that, only about 40%. So it really shows a disparity there. As often happens in Medicaid, when you get these kinds of disparities, we were sued 9 years ago. That has dragged through extensive negotiations, depositions. At one point, the plaintiffs in the case, I think, had a panel of 38 expert witnesses, and the department had me. So it wasn't really a fair fight, but we got to a settlement with dollars from the General Assembly where we have now increased our dental fees for kids by $20 million. And we are also carving out dental from the MCOs, because one of the issues that we heard consistently from the dentists was we just don't like dealing with managed care companies. We're different. So we're going to carve them out. We've contracting with Benecare, which is actually one of the dental benefit managers that was subcontracted to the MCOs. We went through a competitive process to select them. And they will start doing the central coordination of dental services on September 1st. One of the advantages we think that this provides to the dentists is they will have one place to go. Even though there'll be 3 managed care companies out there, they'll only have to deal with one entity, which we think administratively makes, in addition to what we can do to try to amplify the fees, at least we make this administrative piece of it a little bit simpler. And we've been seeing some uptick in our own enrollment of providers as the word about this has gotten out. We're hoping to continue to amplify that in terms of bringing in additional providers. There's some numbers in terms of who we've brought in this summer, in terms of who's come into the program. This by no means has solved the problem. I don't want to gloss that over. $20 million is certainly a better rate for kids. It's still not at commercial rates, so I think dental is still going to be tough. We did put $4.5 million into safety net providers in addition to that, mainly school-based health centers that have dental components, because that's a good place to reach kids. So we're giving out money in the public sector as well as in the private rate increases, because I think it has to be kind of a combined strategy. We'll never be able to do this completely with private sector practices, I think, although we're certainly welcoming their participation. So that's it. That's my presentation.